This video will include psychoeducation on suicide statistics, what persons who are planning a suicide attempt are thinking and feeling, the characteristics of suicide attempts, common occurrences on recovering from a suicide attempt, learning to help others, and finding help for yourself if you are at risk. The suicide rate has increased 24% from 1999 to 2014, with an increase of 2% per year since 2006. Suicide was the 10th leading cause of death in the United States in 2016, taking the lives of 45,000 people. There were more than twice as many suicides as there were homicides. Here are some trends that have been recorded over time and an explanation on how they are collected. The suicide rate is based on the number of people who have died by suicide per 100,000 population. Because changes in population size are taken into account, rates allow for comparisons from one year to the next. We looked at the age-adjusted suicide rates in the United States for each year from 1999 through 2016 for the total population. During that 17-year period, the total suicide rate increased 28% from 10.5 to 13.5 per 100,000. The suicide rate among males remained nearly 4 times higher, with a rate of 21.3 per 100,000 in 2016, than among females, with a rate of 6 per 100,000 in 2016. Suicide is the third leading cause of death for adults ages 18 through 24, and the second leading cause for adults in college. More people die by suicide than from all wars and homicides combined. 71% of psychotherapists report having had at least one client attempt suicide, while 28% have had at least one client die by suicide. One of the primary risk factors for death by suicide is mental illness. Persons with mood disorders are at the highest risk for suicide, especially within the first 5 years of the disorder. 30 to 70% of suicide victims suffer from major depression or bipolar disorder. We will discuss the risk of depression and what the experience of depression looks like. 61% of college students who die by suicide show signs of clinical depression. What is depression? It is characterized by distinct changes in mood and sadness or irritability. It also includes a number of psychophysiological symptoms, such as disturbances in sleep, appetite, loss of pleasure in work, with friends or unusual enjoyments, crying, suicidal thoughts, and slowing of speech or action. These must last a minimum of 2 weeks and interfere with work and family life. The lifetime incidence in the United States is about 12% for men and about 20% for women. Bipolar disorder is also another mental illness that is a risk factor for suicide. Bipolar disorder is characterized by switches between periods of major depressive episodes and manic episodes. It is classified into bipolar 1 and bipolar 2. Bipolar 1 disorder is more severe of the two, where the person experiences a manic episode that lasts at least 7 days, or has manic symptoms that are so severe that the person needs immediate hospital care. A manic episode is when a person feels extremely up, elated, energized, or irritable for a period of at least 1 week. Bipolar 2 disorder is when a person has a pattern of depressive and hypomanic episodes, but not full episodes. A hypomanic episode is similar to a manic episode with less severe symptoms that last 4 days in a row. Schizophrenia is another risk factor for suicide. Schizophrenia is primarily characterized by hallucinations and delusions. Those with schizophrenia are at greater risk for suicide, both in the active phase of the disorder and when they become cognizant of the chronic nature of the disorder. Alcohol dependence is also another considerable risk factor. People who abuse alcohol account for about 1/4 of all suicides, while 50% of suicides occur while the person is under the influence. Next, I will discuss some of the common thoughts and feelings experienced by someone before dying by suicide. Psychologist Dr. Firestone has identified the separation theory, where the person who is at risk has a split within him or herself between the real self and the anti-self. He has identified a critical inner voice that is a negative thought process, which includes negative thoughts on a continuum from mild self-criticism to extreme self-hatred. The suicidal person is characterized by mental pain, and suicidologist Dr. Israel Orbach says that those who are suicidal have a very low tolerance for mental pain. Some common thoughts and feelings associated with suicide include extreme self-hatred, such as, "You don't deserve to live," personalized hopelessness, with thoughts such as, "Nothing matters anymore, you should just kill yourself," pushing away from family and friends, with thoughts such as, "What's wrong with you? Look at all this trouble you're causing the people who love you." Isolation, with thoughts such as, "Just be by yourself, you're better off alone." Thoughts of not belonging, with thoughts such as, "You don't fit in anywhere." And thoughts of being a burden to others, such as, "You're just dragging everyone down. You are such a burden. They would be better off without you." Some signs and symptoms of someone considering suicide include expressions of hopelessness and helplessness, personality changes, depression, and a lack of interest in future plans. Some things to watch out for if someone may be considering suicide include verbal suicide threats such as, "You'd be better off without me," or "Maybe I won't be around." Previous suicide attempts, daring or risk-taking behavior, and giving away prized possessions. As previously mentioned, those who are at risk are likely to make a will or begin to give items away. According to the American Foundation for Suicide Prevention, suicide deaths by method recorded in 2016 show that 51% of suicides were by firearms, 25.9% were by suffocation, 14.9% were by poisoning, and 8.2% were by other methods. In 2015, 505,507 people visited a hospital for self-harm injuries, which suggests that for every report of a death by suicide, about 11.4 people visit a hospital for self-harm. It is unsure, however, how many of them are intentional suicide attempts versus non-intentional self-harming behaviors. Females attempt 1.2 times as much as males, although men die by suicide 3.53 times more often than women. Not only this, but white males accounted for 7 of 10 suicides in 2016 in the United States. According to the National Institute of Mental Health, females are more likely to die by suicide through methods of poisoning, 33%, firearms, 32.1%, suffocation, 25.3%, and other methods account for 9.6%. Males, on the other hand, are likely to choose the following methods: firearms, 56.6%, suffocation, 26.1%, poisoning, 9.5%, and other methods account for 7.8%. But what is life like for a person after he or she has attempted suicide but survived? According to Dr. Firestone, more than 3,000 people have jumped off the San Francisco Golden Gate Bridge to their death. Yet of the 26 that have survived, all 26 report that from the moment they leapt from the bridge, they regretted their action and wanted to live. On a more long-term note, others who have failed a suicide attempt mention that when they attempted to die by suicide by taking pills, they were not happy to wake up the next day, showing that their suicide attempt had failed. Some survivors mention that they still struggle with psychological disturbances, such as depression, bipolar disorder, and substance abuse. Many of them still struggle with suicidal thoughts and chronic ideation, even after surviving a suicide attempt and deciding they want to live. Yet of those who survive a suicide attempt, I want to discuss what recovery looks like for them, along with some demographics. We looked at some information from the 2015 Youth Risk Behavior Survey taken by the American Foundation for Suicide Prevention, and found that 8.6% of youth in grades 9 through 12 reported that they had made at least one suicide attempt in the past 12 months. 2.8% reported making an attempt that required treatment by a doctor or nurse. For those requiring treatment, rates were highest for Hispanic students, with Black males accounting for 4% and Hispanic males accounting for 2.9%, having higher rates than white males, which accounted for 0.9%. We also found that a history of previous suicide attempts is the strongest predictor of future suicidal thoughts and behaviors. In a 5-year follow-up of 302 individuals admitted to an inpatient psychiatric unit for medically serious suicide attempts, 37% of them made at least one further suicide attempt, and 6.7% eventually died by suicide. They found that between 1 and 6% of individuals evaluated because of a suicide attempt eventually die by suicide in the year following. However, recent studies show that it is possible to reduce the risk of reattempts or even deaths by suicide in those who are at risk through interventions such as one-year telephone programs. Other mental health organizations explain that life after a suicide attempt often feels chaotic and directionless, and it takes time to recover both physically and emotionally. This organization also explains the experience of post-attempts at the hospital. Physical injuries are always assessed first, followed by an assessment by a mental health worker. The mental health worker will assess what happened before the attempt and what the person was experiencing in life leading up to the attempt. Following this assessment, the mental health worker assists the patient in making plans for the next few days, as well as making appointments and contacting the person with the right health services. Suicide is a serious matter, and I encourage you to reach out to those you know may suffer from mental health disorders or thoughts of suicide, and often ask them how they are doing. MentalHealthAmerica.net gives us some good tips on how to help someone who may be at risk. If you think someone is considering suicide, make sure that you trust your instincts that the person may be in trouble. Talk with the person and make sure to listen. Ask direct questions without being judgmental, and determine if the person has a specific plan. Get professional help. Do not leave the person alone. Do not swear to secrecy. Do not act shocked or judgmental, but remain calm. And do not try to counsel the person if you yourself are not capable. And for clinicians, remember that when helping someone else who is considering suicide, that no single therapeutic approach works for all people. I encourage you to get help if you or someone you know is at risk. Many individuals who die by suicide do not ever seek professional help, and professional treatments such as cognitive behavioral therapy or dialectic behavior therapy has proven to reduce the number of deaths by suicide. Some resources in your community will include phone hotlines, clergy members, medical professionals, or law enforcement agencies. Here are some resources that we can encourage you to reach out if you or someone you know is in need of help.